Good afternoon, sir.
Good afternoon, Dr. Pilas.
Yes, sir.
How are you today?
I'm fine, sir.
I'm having some little issues connecting with my laptop. But I have connected with my phone, and I can only see you and wrote to me.
Okay.
Can you see anybody other than the two of you?
No, sir.
Okay. Um, just give me a few minutes. I will be there.
No problem.
Make sure you are.
Okay, Dr. Pilas. Hello.
Yes, sir.
Yes, I am on now. Good afternoon to everybody that has joined, and let's start.
Okay, sir.
Yeah.
President of China, to the leader of China, and I want to speak with him.
Good afternoon, sir.
Because I had gone
Good afternoon.
with their work, but during all this year, more than 1 year, I didn't have them. I really wait when our teams will finalize.
Hello, bro. Dr. Rotimi, can you please off mute your...
Oh yes, we are ready. We are ready to see.
Thank you.
All right. Good afternoon, everybody in the house. I can see Dr. Pilas join. I can also see Dr. Rotimi. You're all welcome to this second series of the lecture of VML 810 for year one fellowship. Like I said in the previous lecture, my name is Dr. Ambirni Samaila. I'm a reader in the Department of Veterinary Medicine, Faculty of Veterinary Medicine, Ahmadu Bello University, Zaria. And I have other colleagues that also be joining later, like Professor Jeremiah, whom later you may also likely to join. What I am bringing before you today or into this lecture, like I said in the previous lecture, is my experience in the field. I have been in the field, especially on an ambulatory section of the veterinary teaching hospital in ABU here. And I've been there going to the field with our final year clinical students for the past 17 years. And during these experiences, we have been encountering a lot of diseases of cattle. of small ruminants, and a host of others. So most of the things I'll be discussing with you has to do with field experiences. I'll leave you to check the biology of the causative agents of those diseases and some of the literatures that has to do with the disease. But the clinical science, treatment, and control, especially in the event of outbreaks. These are some of the things I'll be concentrating on. And we are also having a challenge of time. If you notice, we have a host of array of diseases that we need to discuss. But today, if you check the timetable, it's like today is the only time assigned for me aside the one we had last week. So after today's own, I would rather suggest that students can organize themselves and notify me when it is an appropriate time for me to continue with you. Otherwise, we'll take it as a reading assignment. Moreover, you know that the exam is centralized. So regardless of what we are discussing, you need to also do your own to ensure that you cover the syllabus or the course outline as stipulated in the timetable. And if there is any problem or any discussion, any question you want to ask, I'm always available. You can take my WhatsApp number, which Dr. Pilas has already. So for Hussein Abdullahi, for Rotimi, I would like to dictate my phone number to you right away in case of any question after this lecture. You may chat me on WhatsApp, or you can invite me to your WhatsApp group as student, and then we can organize another Zoom meeting at my cost. Let me put it that way, not on this platform because it is already chalked up. So my WhatsApp number is 080 35 96 88 27. 080 35 96 88 27. Dr. Ambirni, my name. All right. Last week, we discussed about contagious bovine pleuropneumonia, one of the endemic diseases of cattle. Almost every pastoral or sedentary herd you find yourself in, you are likely to encounter the disease. That is to tell you we are living with the disease. And we have discussed at length the clinical science, including control measures, because treatment, most of the time, it is ineffective. But we normally go ahead to treat with an intention that those mycoplasma that are circulating within the blood system, peripheral circulation, the antibiotic will eliminate them, but it won't reach where there is sequestrum in the lungs. And that is where treatment is difficult when it comes to CVP. So the best way to handle this disease or to control or prevent is by vaccination. And some of the states in the north, they normally vaccinate annually using the vaccine produced by the National Veterinary Research Institute in Vaughan. So by and large, this is what we have discussed last week. Today, there is another related disease related to CVP, and this one is in small ruminant, particularly goats, and that is contagious caprine pleuropneumonia. Sometimes the causative agent can be confused. Sometimes you may assume it is a disease caused by mycoplasma, Mycotis subspecies, Mycotis large colony. But the real causative agent is Mycoplasma capricolum subspecies Capri pneumoniae. So this disease in small ruminant, particularly goats, is similar to that one of cattle, especially the clinical signs. And it has been reported in Africa, in Asia, in Europe, and also it is endemic in Nigeria. So the primary route of transmission is by inhalation. And like I said, the clinical signs are similar to that one of cattle. And the incubation period range from 6 to 10 days. And the clinical sign that you may notice aside fever, high temperature, you will see that the animal will be having runny nose, nasal discharges, and most of the times, the predisposing factor to this is the nasal bot, Ostrus orbis. So you will see the animal having runny nose, or sometimes you will see being complicated with other secondary bacterial infection resulting into mycopurulent nasal discharge. The animal will be coughing. There is a protrusion of the tongue. As the disease advances, you see this animal will be lagging behind. And most of the time, the goats frequently lies down instead of standing or roaming about. It lies down most of the time. And you would normally observe frothy salivation. Of course, mortality range from 60 to 100%, especially when there is no immediate intervention. Mortality can also be 100%, morbidity, while mortality range from 60 to 100% without intervention. Something that is worth noting of this disease is that despite the clinical signs are similar to that one of contagious bovine pleuropneumonia, in this case, there is no sequestral formation. And in some literatures, you will see that they will normally state that there is no carrier stage in this form of the disease in goats. If the farmer or there is no any intervention, the animal either dies or recovers completely when there is an intervention that is appropriate. So in other words, a carrier stage like in contagious bovine pleuropneumonia, whereby when it is being predisposed by stress or concurrent infection, that dormant sequestrum become active and the animal starts shedding the organism, infecting others, becoming a source of infection within that herd. So in goats, some literature had it that there is no carrier stage. And why? Because there is no formation of sequestrum in the lungs. Therefore, meaning treatment can be effective, and it has been effective, really. So after you might have opened during postmortem examination, what you will see are serofibrinous adhesions. You see fluid within the thoracic cavity, just like in a CVP. Most of the times, one lung may be affected, particularly the apical lobe, compared to CVP in cattle, whereby you see both lungs almost affected completely, becoming fibrotic. Diagnosis. Okay, differential diagnosis. This disease can be confused in small ruminant, can be confused with PPR. meaning there could be in PPR. We remember the disease, the form of disease in PPR. PPR has two forms of the disease: the respiratory form and the digestive form. So when you are comparing CPP with PPR in the same small ruminant, particularly goats, one of the distinguishing clinical sign is that there is diarrhea in PPR compared to CPP. So that can be used as a way of differentiating them. In terms of treatment, we know PPR is a viral disease. So treatment with antibiotic are not responsive, but CPP, the treatment with antibiotic is very effective, particularly when you use tylosin at 10 milligram per kg intramuscular, and especially between 3 to 5 days at the initial stage of the clinical signs. And sometimes you may also use oxytetracycline at 15 milligram per kg, also IM, and when it is administered between 3 to 5 days, is also effective. How do we control the disease? You treat apparently healthy animals.
The Oxytet, is it long acting or short acting?
No, short acting.
Okay, sir. Oh, thank you, sir.
Yeah, so short acting. You know, short acting we normally administer it daily for 3 to 5 days. Yes, tylosin also short acting 3 to 5 days. So if you are to administer tetracycline long acting, at least you have to wait after 3 or 5 days before you administer a second dose, if need be. Yes, so for control, after you might have treated those that have been affected, you can also, the literature has it, although we've not been practicing this, that those that are apparently healthy, when you administer this drug at that same dose rate, it is preventive. More especially, you may not know that those that are apparently healthy may be in the incubatory stage of the disease. So once you administer this antibiotic, it knocks them completely without showing any clinical sign. Vaccines are available in some countries, but I don't know any known vaccine here within the country or that is being produced by our National Research Institute. So this is CPP. If there is any question you may want to ask me, I will attempt to answer. Or if there is anybody that wants to contribute, you can unmute your microphone, and then you can ask me or you can contribute. Otherwise, I go to the next disease.
So what are the economic importance of this CCPP?
Great. Okay. The economic importance of this disease. You know that in this part of the world, in our country particularly, you know that goat is like a delicacy. Almost every restaurant you enter, people will want to prefer goat meat than even beef. Therefore, you can imagine a situation whereby this disease is now ravaging the entire herd of goats or even sheep. Definitely, it will affect protein supply to the population. And in addition to this, you can imagine the cost of treatment. And there are breeds of goats that are now more expensive than our local Sokoto, red Sokoto, Kano, brown, and the rest. And that one comes from South Africa and some of these North Central Africa. Very expensive. So imagine if you have, let's say, 10 or 50 and then you are having morbidity 100%. So if there is no intervention in terms of therapy, effective therapy, you can imagine how much you will lose. Because of recent, as of last year, one of it, about 3 months or so, was priced 70,000 in one of the farms in the north. I don't know as of today. So that 3 months, 70,000. How much more if it is more than that? I mean, in terms of age. So you could imagine you having a morbidity 100% and mortality 60 to 100% in that particular herd of goats. So it's a big loss to the farmer. And aside from the cost of treatment, the farmer may likely or may completely even go out of business. So these are some of the, even if you are to vaccinate, the cost of vaccinating, although it's cheaper than treatment. But as of today, I don't know any known vaccine in the country that can prevent CCPP. So these are some of the economic importance of it. Any other question or contribution? Okay. So the next disease that I may also want to touch briefly. I would have, anyway, let's take this. This black lake or black water. Black lake or black water. It is an acute infectious disease of cattle, although other small ruminants are also being affected, but primarily it affects cattle. And it is caused by Clostridium chobai. Most of the time, the heavy muscles are the ones affected. And it is characterized by inflammatory reactions affecting those heavy muscles and severe toxemia and high mortality. Being a bacterial disease, most of the time, if one is affected, others are likely to come down with it. So the organism, like I said earlier, I don't want to dwell on the biology of the Clostridium, but it's a gram-positive spore-forming bacteria. It is an anaerobic bacterium with an O antigen, and it produces a necrotizing myositis toxin that affects those heavy muscles. And why are they affecting the heavy muscles? Why not other muscles? It's because of the anaerobic nature of it. It is looking for where there is low supply of oxygen. Imagine if it
So it's like we lost you. Hello, sir. It's like we've lost you. Please check your device. Your screen is hanging. Hello, sir. Can you hear me?
Hello?
Okay, sir. Can hear you now.
Yes, the system went off. The application went off. I don't know what really happened. So I am now using my phone to communicate.
No problem.
So, I stated some of the silent points that has to do with the organism, Clostridium chobai, gram-positive spore forming, rod shape, anaerobic, and it has an O antigen that produces toxins that that causes necrosis in those heavy muscles. And that is where the problem is. And I went on to say that why do they like heavy muscles? Why not the lungs? It has to do with where there is less amount of oxygen. No heavy muscles compared to the lungs. So it's because of the nature of or the characteristic of the causative agent, the Clostridium. It is found in the soil, so it is a soil-borne infection. It is reported in all parts of the world, from Africa, Asia, Europe. And in Nigeria, it is enzootic, meaning certain localities, we have outbreaks of it in certain localities, although it is not that endemic compared to contagious bovine pleuropneumonia, FMD, and the rest. Transmission most of the time is through the GIT mucosa, through ingestion, or sometimes if there is any discontinuity on the skin, if there are bruises, if there are wounds that has contact with the soil that is contaminated with the causative agent, they may gain entry. But most of the time is through ingestion. And they will lodge in the GIT, in the liver, in the spleen, until they get a favorable condition where the spore will now begin to migrate to the heavy muscles. And after germination, it produces the toxins that necrotizes these heavy muscles. And that it will start by little swelling. You see the place become edematous, and it becomes hot, and the heavy inflammatory reaction begins. And being an anaerobic bacterium, it produces gas, and those gases are trapped within the muscles. And that is why when you now touch the affected muscle, it is warm, and there are crepitus, meaning the gas are trapped within the muscles. So this is one of the, can I say, pathognomonic or sign that is characteristic of the disease. So you can easily identify or diagnose this disease by palpating the affected muscle. You will feel some crepitus, some gas being trapped within the muscles. And it is painful and hot. But as time goes on, it becomes painless and even cold. That is when it is advancing. And if you now decide to incise it, you will see on some sanguineous fluid oozing out, and the affected muscle become dark. Sometimes it's being described as metallic sheen. So, and it can affect the muscles of the neck, muscles of the shoulder, the gluteal muscles, any other muscle that is heavy. And sometimes during PM, it may also be seen to have affected the myocardium, including the diaphragm that is not really heavy when we compare to the gluteal muscles. So you can imagine anything affecting the myocardium and even the diaphragm. is likely to lead to the death of the animal. The animal may not likely survive for long unless there is an intervention. So this disease is mostly observed during wet season. And why during wet season is that, you know, in this, especially in the north, what we've been observing in the field is that at the onset of rainy season, there's scarcity of feed. And then the grasses have not come out from the soil to the level that they can easily browse. And at the cost of trying to scavenge as they browse, they will be picking the grasses that is very soft, succulent, along with soil, because the plants or the grasses, they have not rooted very well into the soil. So as they use their tongue to pick those succulent, soft grasses, it is being uprooted easily along with the soil. And if that soil is contaminated with the Clostridium chobai, then be sure that it is being taken to the GIT. And that is where the migration starts, from where it is being lodged in the GIT to the heavy mussels. So one of the predisposing factor has to do with grazing at the onset of the rainy season. If there is a way that it can be avoided, especially if we are suspecting a contaminated soil or environment. The incubation period is 2 to 5 days. You can see it has a short incubation period, and cows from 6 months and above can be affected. And when the heavy mussels have been affected, of course, the animal become lamed, unable to stand, unable to walk, and the temperature will rise up to above 40 degrees Celsius, some up to 45. Of course, when there is high temperature, the animal become anaerobic, it refuses to eat, depression will set in, and whenever the animal is off feed as a result of high temperature, then we have ruminant stasis. So these are some of the clinical signs that we can usually see in the field, apart from what the literature is saying. Sometimes death can occur within 12 to 36 hours after the onset of clinical signs. And of course, the course of the disease is 12 to 60 hours according to literature, meaning between 1 to 3 days after the onset of the clinical sign. I've described the pathology that you may likely see, but when this animal is down, leading to death, you discover that the animal will be lying on the side that is affected, the side of the hind limb or whatever heavy mussel that might have been affected. The animal will lie on that side. And if it is the hind limb, the gluteal muscle, you will see that the leg will be stuck out, telling you that it is that side that is being affected. So it's one of the, I don't want to say pathognomonic sign, but it's characteristic of this disease. And then sometimes if care is not taken, you may even confuse it with anthrax, because dark blood that is frothy may be oozing from the mouth and from the anus, and can easily be clotted compared to when it is in anthrax. It clots rapidly. And if the animal is dead, bloats become evident, and there is a rapid putrefaction. So these are some of the things. Then what can we confuse this disease with? Differential diagnosis, apart from anthrax, I mentioned we could have malignant edema, which is being caused by Clostridium septicum that causes gangrenous formation of gangrene in the heavy muscles. Sometimes, most of the time, it is when there is a wound, and this Clostridium septicum now complicates it, and it may present a similar clinical sign with black water. So one has to rule out. But you know, in anthrax, we don't normally open the animal for postmortem infection. Otherwise, you can easily differentiate it. In anthrax, you will see splenomegaly, while in black water, there's nothing like that. In anthrax, you can't see crepitus in muscles. Of course, in black water, we have. So treatment, one can administer 10,000 international units of penicillin per kg, and especially during the mild cases, that can be administered for 3 days. And of course, the only way to prevent is to vaccinate. MVRI will have a vaccine against this disease, and we call it black water vaccine. And it's very
black leg
effective.
or black water? Okay, that's the same thing.
Black water, black leg is the same.
Yes.
Yeah. Black
but
leg.
Concerning
So
the
MVRI,
malignant edema.
malignant edema.
Under differential diagnosis, what is the difference between the two in that quarter?
Between malignant edema and black water.
Yes, sir.
Okay, the difference. The malignant edema comes as an individual case, while black water comes as a kind of group of animals being affected. And in the malignant edema, you could have little or no formation of gas. And when you now take a sample for isolation, you isolate Clostridium septicum in malignant edema, while black water, you isolate Clostridium shobi. Is that okay?
Okay. Yes, sir. Oh. Thank you, sir. That means it's still the same. Since it's still the same Clostridium, it's still the same treatment.
Yeah. Yeah, same treatment can be applied here, being that it is a Clostridium. Yes.
Okay, sir. Thank you, sir. And then one more thing is on the animal lying down on the affected muscle. Is there any reason why it lies down on the affected muscle?
I can postulate, or I can suggest that you know, the animal may want to, if the animal is standing, it can always stand on the side that is not affected. But you know, that side that is affected, the entire weight of the animal will be on that side. So when the animal wants to lie down, you know, sometimes it may not be voluntary, but probably in order to ease the pain, it may likely lie down on the affected side. That's the way I look at it, but I didn't see any literature describing the reason why the animal lies on the affected side. I think it has to do with the trying to relieve itself, and also that side, the animal can easily be pushed to that side compared to the other side that is not affected.
Okay,
It's
sir.
one of the characteristics of the disease.
Thank you, sir.
So any contribution or any question, or you may want to share your experience in the field?
The only thing is this vaccine, when we read, we say prevention best by vaccine, but the availability of this vaccine in Nigeria um, is still a challenge. Most times it has to be from, sometimes even the worm doesn't have it. So, in a place whereby the worm or the vaccine is not optional, I think we can go with penicillin. And does it have any residual effect or any carrier?
But this particular black water vaccine is available in Vomo. It's not an issue at all.
Okay, sir.
It's available. Please.
And in treatment, it
Then,
doesn't have any carrier, right?
The treatment, whether it has what?
After treatment, is there anything like carrier, those that are the carriers?
Most of the time, being they are sensitive to the antibiotic. It is the antibiotics are potent. It clears them from the system. There is not come across any literature that describe that it has carrier stage. Instead, the animal develops immunity, and
Okay,
that's
sir.
why, yes, and that's why you can vaccinate. And then the vaccination most of the time is annual, especially zootic area.
Okay, sir. Thank you, sir.
All right. Okay. Rotimi has gone. I can't see him. Okay. The other disease that I may want to also talk about, if time permits, I want to talk about tuberculosis and probably nocardiosis and aspergillosis. Just battling within me which one to start with. But for tuberculosis, it's another respiratory disease that is also difficult to diagnose in the field. It is an infectious, chronic, and progressive bacterial disease of animals. And of course, humans, being caused by Mycobacterium bovis and other members of what we call Mycobacterium tuberculosis complex, which has 7 members. And the Mycobacterium tuberculosis is one of them, the popular one that we know. Mycobacterium ceprae, Africanum, Microtic, Kennetic, Penidipi. These are members of the Mycobacterium complex. They are, I think, 7 in number. So M. bovis is also so, but most of the time, when you want to isolate or you are suspecting tuberculosis, most of the time you will see M. bovis being isolated alongside sometimes M. tuberculosis. Then of recent, M. africanum, M. avium. So, but the ones that are really ravaging cattle is M. bovis most of the time. Incidentally, I have done my master's degree in bovine tuberculosis, PhD bovine tuberculosis. And my experience in the field, I have tested using tuberculin test, PPD, up to over 5,000 cattle in Adamawa and Taraba states. Almost all the local governments have been there before this act of terrorism become so the way that movement become difficult. So that time the Boko Haram have started, but not to a larger scale. So I was able to get to some of these localities that later was taken over by the terrorists. So, and during this period, like I told you that most of the things I'll be discussing with you are field experiences alongside with the literature. You can read the literature, but let me concentrate on the field experience. So for you to now identify a cattle or a cow that is infected with tuberculosis is difficult. But one of the pointer to it is that you will see the animal, particularly cattle, if they have capricious appetites, the animal will be eaten. Just like in trypanosomosis, the animal will be eaten, but it's not putting weight. And tuberculosis being a chronic disease, the animal will continue to lose weight. The animal will be coughing at the point, and the cough is moist in nature. And aside, you will discover that the temperature is always fluctuating. So, but there are other diseases that can easily be confused or that can have these clinical signs. That is why it is even difficult to pin down and say, I am dealing with tuberculosis. So the diagnosis of tuberculosis most of the time is in the abattoir when the animal is already dead. If you are not using newer diagnostic tools like PCR. Let me not just be jumping. Maybe I will come to test, which I'll tell a little bit on. So for the clinical side, apart from coughing, progressive emaciation, and capricious appetite, fluctuating temperature, any other thing, anything that is making the animal to lose weight, of course, the air code will be rough, sometimes dark in nature. So, and the farm, of course, there is cessation of milk, productivity becomes very low or close to zero. That animal also will not be able to trek for a certain distance, become exhausted, it will be lagging behind, and morbidity may be 100%, but mortality is low. That is the other side of the disease compared to others like CVP. So that is why most of the times, if the animal is eating and the loss of weight is not obvious, the farmer doesn't really bother much in treating that animal or calling the attention of a clinician or a veterinarian. It is when there is cessation of milk, or the animal is not eating, or the animal is lagging behind, or the animal is coughing, then sometimes you may want to attempt treating it with antibiotic. But as it fails, anytime it fails, before you can now call the attention of the clinician. So they normally attempt treating. When they cannot see improvement, then they will now look for alternative. And sometimes the alternative could be quack veterinarians. And before the animal could receive real attention, they might have tempered with the case, meaning a lot of antibiotic might have been injected into the animal. But of course, there is no any effective treatment when it comes to cattle when it comes to treatment. Human beings, we can treat, or they are being treated and they get well. But in cattle or other animals, there is no known treatment, except probably in some isolated cases where primates like are being treated. One of the major problem of treating this disease, it has to do with the formation of granuloma within the lungs. What happens is that once the organism is being inhaled, it produces a local reaction and lodges in the lungs, and monocyte is being attracted. Before you know it, formation of fibrosis, fibrin material will form around the affected site as a result of necrosis. And then that particular point become calcified as a result of massive infiltration of monocytes. So the organism itself now world itself within that formation, such that there is no amount of drug or antibiotic that will reach it. So, and the animal, the organism become dormant and being protected against even the normal natural immune system of the animal. So the animal survive staying in that granuloma until when there is a lot of stress, either due to starvation or concurrent infection. Then it opens up and they are now being shed into circulation and begin to infect other animals, either through inhalation, infected droplets, or through shedding in the milk, sometimes urine and even fecal feces. So one of also the predisposing factor to the infection has to do with communal grazing and communal drinking water source, if it is communal type, where all the grazing animal will now gather along the pond or the river. And within this setting, there's exchange of a lot of causative agents of diseases, and tuberculosis is one of them, especially the respiratory types, and the one that are being shed in feces, in urine. So this is to tell you how difficult controlling or preventing this tuberculosis in cattle is. So coming down to diagnosis. Most of the countries that have succeeded in eliminating or controlling this disease, they have eliminated reservoir of the organism. Most of the time, these are wildlife, depending on which part of the country you are, part of the world you are, depending on the country. Like in Britain, the badgers, these are wild animals that are found almost everywhere within Britain, because they don't normally allow, due to animal welfare, they don't allow elimination of those wild animals. So they become reservoir of this mycobacterium. And whenever they get closer to animal pen or any ranch, cattle ranch, their feces, their urine contaminate the pasture and the environment. And those cattle pick it from there. And before you know it, it is being circulated within that particular herd, especially when the pasture is contaminated. So those that succeeded in controlling or preventing the disease, they focus on the wild animals. And then they also use test and slaughter. So, but
controlling the disease in the wild animals is also another challenge because the animal welfare people also come in. So you can't eliminate all the badgers in the name of trying to control the disease. So, but you can now fence where the animals are kept against the badgers. That way you are likely to prevent wild animals from encroaching where ranches are being established, where their cattle are being kept. Then another way of also controlling the disease is through pasteurization of milk. Because those cattle that are, or those cows that are shedding the mycobacterium in milk, if those milks are not pasteurized, one is likely to contract the disease through this unpasteurized milk. This one is in terms of human beings, but in terms of animals, calves, they got infected through the consumption or suckling of those infected milk from the dam. So how do we now test? There are a lot of tests. Serological tests have been developed, but they have not been proven to be effective. There are a lot of false positive and negative. Otherwise, that would have been the right thing to do at the side of the pen. It would have been much easier. So, but the most accepted test in most countries as a standard is the use of single intradermal tuberculin injection. So, and when you have suspects as a result of that test, then you go for another test called single comparative intradermal tuberculin test. I don't know whether I will have time to go into this, but what the test entails in the single intradermal tuberculin test is that there is a protein that is being produced from the Mycobacterium bovis, the BCG type, that is being incorporated into what is called PPD, purified protein derivative, PPD. So it comes in 2 ml vial. And if you are to test the animal, you inject 0.1 ml at the caudal fold of the animal you want to test, in this case, cattle. So, but before you do that, you have to check the site. If there are ticks or sign of tick bites, then you don't, it will come to when you come to check the result. And also, there are also certain criteria that you have to observe if you want to go into the intradermal tuberculin test, because some animals may not really react positively. I mean, they will not react truly positive when they are positive, especially those that are in advanced stage of pregnancy and those that are having a debilitating disease. Also, the result will show false negative, whereas they are positive. So these are some of the disadvantages of the tuberculin. But the advantage of it is that you can test many animals at a time. So after you inject 0.1 mils of the tuberculin at the caudal fold, you wait till 72 hours before you now come and read the result. And what you have as a positive result is a swelling, like a lump, depending on the reaction of the animal to the tuberculin, if it is positive. So you now look at, you compare when you have the time, the size of the site that you have injected. Then 72 hours, whatever you see in terms of size, you compare to the initial size. That tells you whether you are dealing with positive or negative or suspects, depending on the size. So if you have suspects, literature has it that you have to wait till after 60 days. Then you can now retest. So if after 60 days, which is 2 months, it is negative, then it is assumed that that animal is negative. So, but if you're suspecting in terms of the reaction that you have seen, if it is a suspect, you can also go into what we call single cervical comparative tuberculin test, whereby you are suspect if there is an avium, Mycobacterium avium, affecting that cattle, you can also give this kind of reaction that we call suspect. So if you have M. bovis, it will give you positive. If you have M. avium, it may likely be a suspect. So in order to eliminate whether you are dealing with M. avium or you are dealing with M. bovis, you have to do this single cervical comparative, whereby you inject tuberculin for M. bovis and tuberculin for M. avium. And then use Vernier caliper to compare the sizes of what you have injected. If you have, let's say, for M. bovis, let's say you have the size of, let's say, 10 centimeters, 10 inches. Let me use centimeters to be clear to you. Assuming it is 10 centimeters. And then M. avium, it is now, let's say, 6 centimeters. So when you now subtract 6 from 10, you have 4. So the chart is that you read that result in terms of the positivity of the one that is higher than the other. So in this case, it is M. bovis, because the difference is 6, is 4. So, and if the difference is tilting towards M. avium, then it is not M. bovis. What you have is M. avium. Most of the time, the M. avium, in terms of clinical science, not really of severe nature compared to M. bovis, because the primary causative agent of bovine tuberculosis most of the time is M. bovis, or a certain level M. tuberculosis. So these are some of the tests, apart from PCR that is also, you can say, a gold standard, but it's very expensive. When you have 200 heads of cattle to test, you can imagine the cost to the farmer. So most of the time, countries adopt the use of single tuberculin tests. Then later they go for comparative until they are able to eliminate. So those that are positive, they eliminate it by slaughter. Those that are free, they are being released. Of course, there is no known vaccine, to the best of my knowledge, that can prevent this disease in animals. So, is there any question you may want to? I have lumped a lot of things into this. So, I don't know if there is any question you may want to ask or you may want to contribute. Hello? Anybody?
Yes, sir.
Yes. Any question you want to ask or you want to contribute? I have lumped a lot of my field experience into the lecture, and it wasn't really sequential. I was just discussing it generally. So I don't know if you have a question or you want to contribute, and go ahead.
For me, I don't actually have, just that
the single intradermal tuberculin injection site. It was quite interesting. Just that at the end, it's still not guaranteed that even with the result you have that it is tuberculosis.
Mm. And the most disturbing aspect of this disease, most of our slaughter slabs and abattoir, especially here in the north, my experience is that, especially in this part of the country, in the northern parts, almost every slaughter slab, where if they slaughter up to 20, they likely see one or two that have been affected with tuberculosis at PM during post-mortem meat inspection in the abattoir. So you will see a lot of these granulomas, some in the lungs, while some you will see it within the visceral organs, affecting the liver, affecting the spleen, affecting the mesenteric lymph node, and so on. So depending on the route of the infection, if it is through inhalation, the lungs have been affected. So if it is through injection, the visceral organs have been affected, and we call that extrapulmonary infection. It's a disease of interest because of how difficult it is to treat. That is why any human patient that is undergoing this treatment, sometimes they abscond as a result of the long duration that normally take for them to be completely free of the disease. And that is why they introduce what they call DOT, that is direct observed therapy, whereby the patient will come to the clinic and then they will give the tablet or the injection to the patient to take immediately in front of the personnel, because they realize that when they go home, they hardly take. You can imagine taking injection or tablet for a longer period of up to 2 months, 1 or 2 months, depending on the severity. So in animals, it's very, very difficult. People are still researching into it. So you can also join the research team. There's a lot to it. So for the purpose of this lecture, we may want to stop here. Plus, if you have another question pertaining this too.
No questions, sir. We are just praying that God will help us in Nigeria to come up, because some of these things, you will see it in the abattoir, you will see it even in the community where I am, and even to tell them you're not supposed to touch this meat or you're not supposed to eat this organ, they are not listening to you.
True. You're right. And you see, sometimes, anyway, let me not waste our time. Dr. Kaltungo is standing by to also continue with the lecture.
That's true.
Let this so that to allow her also have the time, during fasting. Some of our brothers and sisters are fasting. So like I said, you can organize yourself into a WhatsApp group. And if there's any free period that you want me to come in, you can notify me of the time and the day. But based on this official time, seems that today is the end of my lecture, because I didn't appear again anywhere within the timetable. So thank you, Dr. Pilas.
Okay, sir. I'll look into that, sir.
All right. So I will notify Dr. Kaltungo to take over.
Thank you, sir.
You don't have to notify me. I'm already here. Hello?
I think he has gone, sir. He has gone, ma.
Oh, he has gone. If
Yeah.
we're eating into your time. So good afternoon.
Yes, no.
Uh-huh. Who was the one that called me yesterday?
I'm
Dr.
the one.
Eh? You
I'm
were
the
the
one,
one,
Dr. Pillar.
you were the one that we had a discussion with last week, I suppose.
Yes, it's still me.
Okay. I hope we'll be able to cover much like Dr. Mbiri said. If you are unable to cover, then I think the remaining topics maybe we'll have to arrange for extra time outside the official time. So we
Yeah.
still have for me, I still have 4 topics to take. That is PPR, pox, contagious ecthyma, and heart water. So we'll start with I told you, the person that asked me yesterday, actually, I don't know, maybe it's Dr. Pilas, I don't know. I told you I taking
It's me.
it came on the schedule. So we're starting with PPR for now.
Okay, ma.
So do I have to share my slide?
Well, I appreciate it. That
The
I will
Dr.
appreciate.
Ebini did not share his, and why didn't you complain?
I have already complained. Trust me now. I complained, and he said to me that that he's sorry that
Okay.
the time given to him was short, and so he was not able to prepare something that can be
It
presented.
is time given to all of us now. Even today, I was trying to do some things, and there was power failure. So it's still the same thing. It applies to all of us.
Thank you, ma. I will
So
appreciate it.
let's see how it goes. Huh?
I'm seeing it, ma.
You are seeing it now, isn't it?
Yes, ma.
Okay. So thank you. Let's start. So as I told you earlier on, we are talking. We're starting with PPR, which is a synonym acronym PPR, pest predominant, which is also known as goat plague or Qatar. Come to know why it is called Qatar. Well, like I told you last week, are you listening to me?
Yes, ma.
Aha. I'm not dealing with taking all these things in detail. I've told you I'm just going to touch it superficially. Since you have the topics, you are not undergraduate, you have to go and do extra work to dig up all additional information on the topics. So for PPR, the etiologic agent is the PPR virus, which is a mobile virus. The PPR virus affects small ruminants, like you said, pest of small ruminants. That's just what the PPR means. So it affects small ruminants. So it is related to other viruses in other species of animals, which you'll come to know about later. So within the mobile, the PPR virus, we have 4 lineages. Lineage 1 and 2 have been reported in West Africa. Lineage 3 in East Africa, Arabia, and Southern India. Then lineage 4 has been reported in the Middle East and Asia subcontinent. Then for the epidemiology, it is a disease of sheep and goats. But you can see that goat is highlighted because it's more devastating in goats. So, well, most of the cases, the very serious clinical manifestation of the diseases have been reported in goats than in sheep. So the disease is endemic in Africa, Nigeria inclusive. Then outbreaks have been reported in Northeastern Africa, Middle East, and in Asia. It causes a high mortality in goats. It causes a high mortality in goats. Sorry, please excuse me 1 minute. I told you that don't go and attend to. It's the one now, that's why I was doing. That's I'm gonna lecture. Sorry, please. Hello.
I'm with you, ma. Continue.
Sorry, I had to attend to another case. You know, I'm on the clinic floor. A client just came into my office.
Okay, and
So,
let me quickly say this. In
sorry.
case you have your own time, in case you have any free time, just communicate with me so that I can schedule a private meeting whereby we can actually continue any lecture that we not be with.
I have your phone number. Maybe you were the one that called me yesterday,
Yes, ma.
but I didn't save it. Maybe after the
Okay.
lecture, we'll talk about that.
Okay, thank you.
So it causes high mortality, very high. That is why it is even called goat plague. It causes high mortality in goats. You know, for the disease to occur in a farm, usually when these cases are reported in our clinics, the first question we ask client is that, was there a new animal that was purchased? Because most of the time it's usually caused by introduction of new animal into the herd or flock. So this is one of the ways whereby this disease is being introduced into the herd or flock. Or in some other cases, like the usual practice here, sometimes clients take some animals to the market for sale. If they are not bought in the market and they return them back to the herd, it can cause an outbreak. So you have to be very careful. Any animal that is coming into your herd, you have to at least segregate or quarantine the animal for some maybe at least 2 weeks before addition. Even if not for PPR, for any other disease, a lot of diseases come as a result of new introduction of animals. Then the transmission is usually by close contact with infected animals, or even their secretions. So coming in contact with infected animals or termites, even the personnel that takes care of the animals can transmit this disease, because the virus can be carried from one place to another, even on inanimate materials. That is what is meant by termites. Large amount of viruses are present in secretions. All the secretions, the nasal secretions, the ones from the mouth, even the feces, especially the feces, has a lot of, is very rich in the virus. So a healthy animal or a susceptible animal coming in contact with these body secretions can cause infection. Infection is mainly by inhalation. So inhalation of the virus, but can also occur through the conjunctiva or the oral mucosa. So contamination of feed or feed materials with secretions, and then another animal coming in contact with such feed material can also cause an infection. That is by ingestion. So, but mainly it is usually by aerosol. Then after it is being transmitted, how does it really establish in the body of the animal? So that is the pathogenesis of the of the disease. So after inhalation and or ingestion of the virus, it localizes in the upper respiratory tract and establishes an infection there. From there, it goes into the bloodstream and causes a viremia. So after that, it gets disseminated into the body, and usually it targets lymphocytes, the alimentary and respiratory mucosa, where it causes a lot of havoc, especially. That is why it is called pneumoenteritis. Well, I didn't put it in the the synonyms, but it is also called pneumoenteritis complex. Pneumorespiratory enteritis, that is the alimentary tract. That is where the clinical signs are majorly manifested. And then from there, when they get into these systems, they now cause the clinical signs and the lesions that are being seen in this. So after they have been, the disease is established, the clinical signs that you see in the sick animals include a high fever, fever of over 42 degrees or even above degrees Celsius. So the animal will have a fever. Then you have serous nasal discharge, which after a few days progresses into purulent nasal discharge and even ocular discharge. So then necrotic stomatitis. That is why during clinical examination, when you open the mouth of the animal, there's this offensive smell from the mouth, and because of this stomatitis in the mouth, and then bacteria in the mouth to act on the cell debris there and cause an offensive smell. So diarrhea in this disease, of course, is a viral disease. Is characteristic of viral diarrhea. So one of the things, maybe one of the signs will be what you use. You need, when you have diarrhea, you need to differentiate between helminthic diarrhea, viral diarrhea, and bacterial diarrhea. There's a difference in all this in the clinic. So let me just shed some light on that. When you have helminthic diarrhea, usually the diarrhea is usually pasty and does not smell. Then for your bacterial diarrhea, it is smelly, but what differentiates it from viral diarrhea is also smelly, but the volume in viral diarrhea is more than that in bacterial diarrhea, and also the frequency in viral diarrhea is usually more than the bacterial diarrhea, even the consistency. The viral diarrhea is usually more watery. And so because of that, if you don't act promptly and appropriately, that is by rehydrating the animal can even die of dehydration even before not even due to the etiologic agent. So dehydration is usually evident when you have the animal passing diarrhea frequently, and the diarrhea is usually very frequent. So you also have respiratory distress. You have clinical sign. You have there will be matting of the ears, that is the nasal orifices, and then even the eyes will be matted with the mucopurulent discharge. So, sorry, you wanted to say something?
Concerning the diarrhea, what of the natural diarrhea that comes through injection of oil?
Oil.
Yes.
How natural diarrhea that comes through injection of oil? I don't understand, please. Maybe you should
This
rephrase
induced diarrhea.
That is when you have maybe a problem and then you induce the diarrhea.
No, there are animals that will leak oil in the house, especially in this rural environment.
Usually when animals, okay, I understand your question now. Sometimes animals get access to oil and they take in a lot of it, isn't it?
Yes, ma'am.
Is that what you're asking?
Yes, ma'am.
And in fact, there's another type of diarrhea, the nutritional diarrhea. Some of these things, these ones I told you are diarrhea that are very confusing. You may be thinking, because you see, in viral diarrhea, bacterial diarrhea, you have a temperature, isn't it?
Yes, ma'am.
Most of the time when you are making a diagnosis of a disease, you don't base it just on one parameter. Like let's say diarrhea. When you see diarrhea, this is clear cut, it is this disease. No, you have to start. I think I told you this last week. You start from the history, then you come to clinical science before you take samples and whatever. So from the history of this one, of course, the history is that the animal consumed oil, and then from the clinical science, you see diarrhea, but the diarrhea is not going to be very watery like what you have in viral diarrhea. But it can be confusing sometimes with helminthic diarrhea. But when you have that helminthic diarrhea, you also have associating signs. You can have rough hair coat, you can have maybe pale mucous membrane and things like that. And there's no temperature in that type of diarrhea. But in this viral or bacterial diarrhea, there's an increase in temperature. So with some of these things, you'll be able to differentiate. And usually, when you have, it depends on the amount of oil taken, though. But most of the time, when you have diarrhea due to that, the diarrhea is usually shiny, which also indicates that there's oil, that the animal consumed oil. So some of these things you can use to differentiate between these diarrheas. Sometimes even in diarrhea, you have a history of change in feed or something like that. The animal is not tolerating what you give to the animal. So because of that, you have this maybe sudden change in feed. That is the history. And then you have sometimes you even find undigested feed material in the feces of the animal, which shows you this is something that has to do with nutrition. Are you okay? Should we continue?
Yes, ma'am.
So I think the last one I was saying was respiratory distress.
Yes, ma'am.
It affects the respiratory system. You have respiratory distress. In fact, when it starts, it can start from the upper respiratory tract. As time goes on, it moves to the lungs. So when you do an auscultation of the lungs, you can you'll be able to hear crackles, which is also called moist trills of the lungs. So because of that, the compromise in the lung, the animal is not able to breathe very well. So the respiration is going to be shallow and even faster than what it's supposed to be.
I'm
And
with
then,
you.
sorry?
I'm with you.
Okay. So this is just a picture of what I was talking about. You can see the nasal discharge, isn't it?
I'm
Purulent.
seeing.
Uh-huh. So the next one is you can see, usually you have when you have a case of PPR, the first thing you see is you see the mucous membrane of the eyes being reddish, congested, depending on I've told you how it comes about, isn't it? The animal has the diarrhea, it's losing water. So there's going to be human concentration, and because of that, and even coupled with the fact that there's fever, so you have congested mucous membrane. And then also the way you have discharge in the nose, mucopurulent, you also have in the eyes. Then in the mouth, when you open the mouth of the animal, though it's not showing in this picture, I'm just saying it. When you open the mouth of the animal, you see erosions. I hope you know the difference between erosions and ulcers. Or you have forgotten. Hmm? You are not answering. Forgotten.
Ma'am, forgotten.
Erosion is still is English. Erosion is something that is superficial. Something when you say even road, you say erosion. Something is
Yes.
eroded. It's something that is the superficial layer is being washed off. But when the ulcers are deeper than erosions, so like what we said, was it last week? We talked of FMD. The 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 vesicles after the rupture they leave ulcers, so they are deeper than erosion. Erosion is just sometimes you can even use your hand to peel off the lining that is sloughing off, so that is erosion. So in PPR, rinderpest and its brothers and sisters, you know the brothers and sisters of PPR, do you know them?
Yeah. Yes.
You have canine distemper in dogs. You have measles in human beings. You have porcine distemper in seals, the sea animal, and all in what again? So they have exactly the same clinical signs. What all these diseases I've mentioned. So that is what. So you find erosions in the mouth. This picture depicts exactly what PPR looks like if you have seen it before. Have you seen one case before
Yes, ma'am.
of PPR, isn't it? So it's not new
Yes,
to you.
ma'am.
So it's exactly what you see in a typical case of, or a classical case of PPR.
Yes, ma'am.
So how do you make a diagnosis of it? For an experienced clinician, even from the clinical science, you can make a diagnosis of it. All these ones are, let me say, Turenchi. They are tests that, yes, we know they exist, but we don't do them here. I don't know, maybe if you have to do them, if you need to
Okay.
do them here, you have to go to maybe some more sophisticated laboratories. So, well, we do our own testing majorly based on clinical science. Our diagnosis basically based on clinical science that we see in the field. So when you see a classical PPR, you'll be able to recognize. But if you want to go further, in case maybe of research or some other things, the diagnostic technique is usually virus neutralization test and immunohistochemistry. But more recently, Other tests like the polymerase chain reaction have been used to diagnose PPR. Then for the treatment, typical of a lot of viral diseases, there's no specific treatment for PPR. So you treat the symptoms that you are seeing. If you have diarrhea, you try to manage the diarrhea, you rehydrate the animal. If it's, you can use antibiotics, because most of the time it's not the virus that does the harm, it's secondary bacteria complication that causes a problem. So you give antibiotics to help take care of the secondary bacterial infection. Whilst you do that, the body system will help to take care of the virus itself. But some researchers have tried to use hyperimmune serum, that is, they infect some other animals, harvest the serum, and then use in treating sick animals. So, like I told you, the last point there is symptomatic treatment. So any symptom you see, you try to take care of it. You see, even for the fever, sometimes you can use these NSAIDs to take care of the fever when the animal is very sick. You try to.
Piroxicam.
Sorry?
Piroxicam.
It's one of them. It's an NSAID. You have a lot of them. Piroxicam is one of them. Diclofenac is one of them. What is it? Well, this one again? Flunixin. Those are, any of them can serve, depending on which one is available and more convenient. So that is that for the treatment. But usually you can also, like I told you, management. Management is very important. You know, because of the lesions in the mouth, the animal may not want to eat. So you try to encourage the animal by giving feed that is soft, like this wheat offal, that, like what I told you in FMD. Because of the lesions in the mouth, you will not want something that is hard, that will cause more injury to the oral mucosa. So you just give something that is soft for the animal, so that the animal will be able to at least take in something. So for prevention and control, well, in some countries, well, not in some countries, PPR is a reportable disease, but we don't report it because it has become part of us. We have agreed to stay with PPR and we're living with PPR. So just for you to note. So, but for this slide now is prevention and control. How do you prevent and how do you control? Well, we have talked about quarantine of Muce toxins is usually the main, that is how the infection or establishment of the infection comes about in the herd or in the flock. So any new stock should be quarantined and look at it thoroughly, and that is keep it for at least 2 weeks in quarantine before you add to the existing flock. Then, well, in Nigeria, we're lucky we have the vaccine. There's the PPR vaccine. It is produced in worm, so it can also be used annually to protect animals against PPR, especially goats. Even within the goats population, the West African dwarf goat is more susceptible to PPR than the other ones. The Sahelian goat and sheep are two more resistant than the. So you vaccinate every year. So then when you notice that there's a sick animal in the herd, you try to isolate or its spread. Whilst you isolate, you can try, you may want to give a prophylactic treatment to the other animals that have come in contact with that particular animal. Well, if you have questions, if you don't have questions, that is all I have for you for PPR. You can let me
Yeah. The question is,
as you want on PPR.
yes, on PPR, can that our African magic work, the use of alum?
Alum.
Mm.
How do you use alum for PPR?
Although there's no blister here, it's just yeah.
Alum will not work for PPR. Don't know. But what did I tell you about alum? I told you, I was the one that told you about alum, I can't remember.
Yeah, he said it's majorly for blisters.
Blisters. You say blisters. Well, let me say there's a program they say mind your language. What do you mean by blisters?
Something that is found in, what do you call it again?
It's found
The
where?
foot and mouth disease. That we normally say in FMD.
Well, you can see. So blisters are just some eruptions on the skin that
Yes.
is fluid filled, isn't it?
Yes.
Blisters at the end of the day can develop to be, they can become larger, and they can become larger to form things like vesicles. So it's just a fluid filled lesion that's called a blister. So well, for FMD, I don't know, maybe you didn't really get what I said very well. You have lesions on the feet of the animal. So you want it to regress faster than normal. So that is faster than the usual convention, faster than when you use the conventional treatment. So what I said was, you can use alum. Alum is an astringent. So when you apply alum on it, it pulls water away from the tissue, makes the tissue to shrink, and then it heals faster. But in this case, it's not exactly what you have in FMD. You understand?
Yes, ma'am.
So you see, one thing again, I want the only thing that you may want to, maybe what you're asking about alum is just the lesions in the mouth, isn't it?
Yes, ma'am.
It might not be very applicable. Well, you can use there are some preparations that are meant to be used in the mouth, which I can't remember the name now. But one of the trade names of one of them that I know is Bonjela. It's an oral antiseptic. So at least if you really want to use something in the mouth, you can use that to clean the mouth. Oral antiseptic helps. I can't remember the ingredients, the active ingredient, but the trade name is Bonjela.
Okay.
So that is one thing you can use in the mouth. So you can use it at least as an oral antiseptic to reduce the microbial load or whatever in the mouth, so that the lesion can heal faster. But one thing is, a lot of lesions in the mouth, when you take care of whatever is causing the lesion, it heals on its own, because the mouth, I don't know, the way God has made it, it has the enzymes or whatever in the mouth help wounds in the mouth to heal faster than in other parts of the body. So
Yes.
what you should do, you just take care of the secondary bacterial infection, and then what you should do is just, at least for the nails, the nostrils will be blocked with those discharges. You should try and remove them from time to time so that the animal can be able to take in air, and then the one on the eyes, you can also clean them off. I think that is just what you can do as in to manage this thing. Then, well, if you have vitamin C, can also be used for this condition, because number one, it helps the immune system, and then also it also aids wound healing. So it's one of the things that you can also use in, I told you it's not a rule of thumb. It's just what you think will work best for you. That is what you do, because
Yes.
though there's no particular treatment for PPR, but what you do that works for you is what you just adopt for the treatment of PPR.
Yes.
Is that clear?
Yes, ma'am.
So do you have another question?
None other question. No other.
There's
No
no
other
question.
question.
PPR is an endemic disease. You cannot practice without coming across PPR. You will always have PPR. So when you have PPR, the client are always very jittery. So you have to do something fast to help the client. So, and then you have to help the client in the present situation, and you also have to advise the client that is in future, what should the person do to forestall PPR. I think we have discussed this. So these are the things you have to put into consideration. You have to tell your client so that you take care of PPR now and in future. So if you don't have any, you have questions.
No, ma.
There are no questions, then I think we should take the next topic, which is pox.
Go
Okay.
ahead, ma.
So the next topic is pox.
Ma, can I ask something on this
Please.
box? There are some cases I've treated, I snapped. I don't know if it would be possible for me to share it with you as we are looking at this box so that
Maybe when we
anything
come,
can happen.
when we discuss, when we finish with the pox slides, you make reference to that your case. What were the challenges? What do you
Okay.
want to improve what you did? Hmm?
Okay.
Maybe I'll be learn
Okay.
from what you did. Maybe you did something that I don't know that I want to. Or I also want to learn from you. So at the end of this presentation for POX, just bring up your own so that we can discuss.
Okay, ma.
So, well, POX, there are a lot of POX in they affect almost all animals. The only exception I think is dogs that do not have, that has not been reported in POX, but every other animal I think POX has been reported in this thing. So for cowpox is a very rare disease. So, but it is caused by virus of the genus Orthopox virus in the family Poxviridae. Well, since I have started practice, I've never come across cowpox before. The only ones that are common are the sheeppox, the goatpox, and the lumpy skin disease. So these three that I just mentioned now are in the Capripox genus, also in the family Poxviridae. So they are all pox. We have pox in horses, we have pox in even in cats, we have pox. Well, for the cowpox itself, it was reported in rodents in Europe and East Asia. But for now, like it's almost non-existent. The pox this thing is not there. You see, before, I can't remember the years now, before it was reported that smallpox has been eradicated in human beings. So during that time when they were vaccinating in Europe against smallpox, so they now realize, they don't vaccinate smallpox with smallpox virus. They used to vaccinate with this vaccina. So it's not the cowpox virus, smallpox virus, but it was protective against smallpox. So that was what they were using to vaccinate against smallpox. So they now realize that the humans that were vaccinated against cowpox that worked with cattle were transmitting the disease to these cattle. So that was how maybe that is what they are thinking, that is why they don't have cowpox presently, because smallpox has been eradicated. So they do not vaccinate against smallpox again. So they think because of that, they have stopped vaccinating against smallpox, and they thought then that it was that vaccination in humans that was really causing pox in cattle. So since there's no vaccination now, so it means there's no pox in cattle. So, well, then it was said to be a disease of rodents, that it was rodents that were carrying the pox. That was that at least sometimes cattle are accidental hosts. They were thinking it was from human beings, they were thinking it was from rodents, but the bottom line now is that it is a very rare disease and it's almost non-existent. So,
Can I suggest something?
Please do.
Since the disease is not really that common in Nigeria, maybe we can look at sheeppox that is very common.
No, I have only very few slides because it's not important, so I didn't really take it as important. The one that is important
Uh-huh.
is
It's
either the
not.
both pox and then LSD. I have the slides there.
Uh,
Don't worry.
let's move to the
We're
next
not
one.
taking we're not taking much time there. So you're suggesting we should just leave everything about this, but the pathogenesis for this pox and these other pox are the same. So at least these first 3 slides is just like an introduction. So for the pathogenesis is the same thing as the other pox viruses. So usually, well, for this, the first point here is usually the pox lesions are found around areas that less hairy areas like the teeth and other. So that is also what you see in sheep and goat pox, but notwithstanding, nowadays, sheep and goat pox, you can see it all over the body of the animal, just like what you see in lumpy skin disease. Well, the pathogenesis of all of them starts with an erythema. I hope you remember all these terms from your undergraduate, what erythema is, what hyperemia, you know the difference between hyperemia and erythema? You've forgotten. Well, hyperemia.
Edema, accumulation of water.
Sorry?
Continue, ma.
I'm listening.
I say edema has to do with
No, not edema, not edema. Erythema, this second point here.
Oh.
Erythema and hyperemia.
No, ma. Please refresh my memory. Yes, ma'am.
You see, hyperemia, when you see something is hyperemic, you have plenty of blood supply to that area. You understand?
Yes, ma'am.
That is hyperemia. So hyperemia, at the end of the day, develops into erythema. Erythema is just when you have red patches on the skin.
Okay. Yes, ma'am.
So you have erythema, then you have papules. You know, also you remember the difference between papules and pustules?
Yes,
papules are just raised areas. When you say pustules, it means pustules, they are raised areas, but they have pus in them.
Pus inside it. Yes, ma'am. I understand.
Eh?
I understand.
Aha. So when you have an area, an erythemic area, then it develops, papules develop from that area. So the papule is going to be raised above the skin. Then it will have like a ring around the base. I don't know if you can imagine what I'm saying of hyperemia.
Yes, ma'am.
So after that, it forms vesicles, then they become then pustules, and then when they dry up, they form scabs. So that is how it comes gradually. And this is just diagnosis, viral isolation, and this. Then treatment is also palliative. We'll still come to that later. Then I hope I have, okay, I have it. Then control is just by sanitation. But the other ones like the LSD, there's a specific way you control it. This is just maybe general for pox. And the other ones that are more important are the capripox viruses, which has sheep pox and goat pox. The 3 viruses are endemic in Africa, Middle East, Central. That these 3 viruses, I mean, is sheep pox, goat pox virus, and then the lumpy skin disease virus. So they are endemic in this part of the world. Then for lumpy skin disease, also it has also been reported in Europe. Lumpy skin disease, I don't know if you have seen one before, because here in Zaria it's very common.
Yes, ma, it's common here.
It's also common there. What of the goat and sheep pox?
I've seen sheep pox, but I've not seen goat pox.
And is it more common in goats than in sheep?
I've seen sheep pox.
Presently, now, there's an outbreak of this pox, sheep and goat pox in Zaria. Because some of my students came to me, some came yesterday, some came today. They have a case of pox. How are they going to go about it? So there's an outbreak. So even in, you say, where do you stay in Kebbi?
Yes, ma'am.
They have these things in Sokoto. Why is it I don't have it in Kebbi? Hmm?
I don't know. I know I have seen goats, sheep pox, but I've not encountered goat pox here.
The goat pox is okay. So the viruses are mainly found in the oral, nasal, or ocular secretions. So these secretions can be transmitted between animals through this secretion, and then also it has been reported to be transmitted by inhalation or indirect transmission by termites and the likes of them. But for lumpy skin disease, it's usually insects that have been incriminated in the transmission of lumpy skin disease virus. So, and that is why most of the time the prevalence is usually higher in the rainy season because of increase in the insect population during that time. You know that I have a lot of grasses and things like that. So we have more insect and even the moisture. So you have more insects during that time. That's why it's more during the rainy season. So for sheeppox virus, the incubation is 4 to 8 days, and then it's a little higher in goat pox and lumpy skin disease, which is 4 to 15 days. So after infection, if it's LSD, insects, and the other ones by inhalation or whatever, then the virus replicates in tissues. After the replication, it goes into the bloodstream and causes a viremia, and afterwards it localizes in the lymph nodes. So because of the viremia, it spreads throughout the body, and then they have problems in the liver, the lungs, and in the spleen. That is why you see especially for lumpy skin disease, as far as I'm concerned, all these pox viruses, lumpy skin disease is very important because number one, of the economic value of the animal that is affected. Because if you see a case of lumpy skin disease, you yourself, you even pity the animal. So you see, it affects the liver, and because it affects the liver, you know the liver is responsible for production of what is it called now? Albumin. Albumin that helps to maintain the oncotic pressure in the body of the animal. So because of that, the production is of albumin is affected, and that you have edema in dependent areas of the body. You see edema on the feet, around dewlap, and the scrotum or the udder if it's a female animal. And then you have respiratory problems because it also affects the lungs of the animal. So after the course of the spread of these things, then later on, then you find nodules on the body of the animal. So before the nodules appear, you may not be able to make a clear diagnosis of this disease because the signs are not very specific to lumpy skin disease. You just keep seeing that the animal is thrifty, and the animal is not feeding well and all that. You may just be thinking what is except it's only after about 2 weeks when the nodules manifest. That is when you can really say yes, it's lumpy skin disease. So then the clinical signs, you have the nodules on the body, almost all parts of the body. For this other pox, not the cowpox. The other pox, you have the nodules almost on all parts of the body. So the animal, they have conjunctivitis, rhinitis, lymphadenopathy, especially of the prescapular lymph nodes, since it's one of the superficial lymph nodes. Even the other superficial lymph nodes, like the precrural, the parotid, can also be affected, but most of the time it's the prescapular that is mostly affected. So because of the conjunctivitis, you see the eyes of the animal will be red, you see discharges from the nose, from the mouth, and the animal, in fact, you see the animal will not feed, and the animal will Usually the animal stays like that for a long time after, if there's no medical intervention, it can be more serious. But if there's a medical intervention, at least the cause of the disease is not very long. It's only that after some time, after it heals, it leaves a permanent damage on the skin of the animal, which affects the market value of the hides. So this is a picture. This is one of the pictures of the case, one of the cases we handled during our own fellowship program in one of the villages here in Zaria. So you can see the nodules. It's just that we didn't take a picture of the feet. You would have seen even the feet, and then even the dewlap. From here, you can see that at least you can see the edema. It was looking more. Maybe the picture was not well taken, but this is just exactly what we saw. You see the edema of the dewlap and then the skin lesions all over. Then after some time, the skin lesions rupture, and then they leave a depression, which is referred to as sit fast. So it's this depression that usually causes that reduces the market value of the hides. But for those that eat common, I don't think it's really a problem. You can also see this animal, the lesions are all over the body, and you can see even the jaw of the animal, the way it is. So you have edema because of reduced pressure. Then for prevention and control, it depends on what the vector. Usually, what is advised is control insects, especially for lumpy skin disease. Since they are the ones that transmit the disease, control insects. You can use pour on acaricides on the animal from time to time, depending on the one you are using. There's this one we used during our fellowship program. Yeah, I remember the name, fipronil. Fipronil is a pour-on acaricide that lasts for up to about 3 months on the animal. I don't think there's anyone that lasts as long as that. The other ones, just a few weeks or even at most 1 month, effect went away. But for this one, it can last for up to 3 months, after which you should repeat, especially during the rainy season, so that it can repel insects from the animal. And then another thing is if you can clear bushes around the house or the animal pen, so that at least you discourage insects from coming around that area. So if possible, early detection of outbreaks. If you have early detection of outbreaks, then you take care of the animal. It makes it a lot better for the animal. Then also restriction of animal movement, so that the animals any healthy animals will not move into areas that are that have an outbreak of this. Then there's also preventive measures which is done using by vaccination. You can see the name of the vaccines for sheep, that is for sheep pox, and this one for goat pox. Then for cattle, the one that is commonly used even here in Nigeria is the Nittling strain of the virus, which is used to protect or cover the animal against lumpy skin disease. The other ones, maybe you will say they are not important. These ones too are not very important because, like the last one, it's something I just want you to know they exist. It's not as if, but the ones that are important to us are the sheep and goat pox, then the lumpy skin disease. These ones I just mentioned so that you not hear them somewhere and just say you have not heard them before. They are just pox in horses, and then these ones, the both of them are pox viruses in horses. So I think that is also the end for pox, except if you have questions on pox, please ask questions. Even if you don't remember the questions now, maybe later if you remember the question, you can still contact me. But for now, you can ask some questions.
Okay. I wanted to ask if pox in sheep is self-limiting, does it recover within a period of time? That treatment.
Yes, it's self-limiting, but you will not want the animal to suffer, go through all the stress of because before it clears, it takes some time. You know, the animal will not be able to eat. The animal, in fact, your mind will not be at rest if it's your animal. So likewise, the client's mind will not be at rest, so you will not leave your neck. So it's better you intervene so that you can shorten the course of the disease.
Okay. So
Lot
what's
of,
the
like even the one we are going to discuss later, contagious ecthyma is self-limiting, but you need to do something. Like if a client comes to you now and says he's heard of animals have pox, and you say, okay, no, you don't have to do anything about it, it's self-limiting, you run yourself out of business. And in fact, even the oath you have taken that you would help to alleviate the suffering of animals, you see, you have not fulfilled it. So you need to do something. Yes, we know it is self-limiting. Even if you have kata is self-limiting. It doesn't kill, isn't it?
It's true.
But you want to take something so that at least you feel better.
Yes, ma'am.
Even diarrhea, they said any diarrhea of any etiology is self-limiting. But it's self-limiting. If you live, you will suffer before it goes. So you need to do something.
Yes, ma'am.
Talk.
That will be all, ma'am.
I'm still listening. I want you to ask questions.
It's just that case now, the one I handled on sheep and
Okay, I've been forgetting about it. Okay, tell me about it.
okay. The clinical science was very, very clear. I snapped them. But then I don't know why. When I treat, you will see the animal becomes stronger and respond and it is before, unlike before. But the lesions that are present on the body, it does not spread, but it is not reducing.
It will take time. It will go.
Okay.
It will take
So
time.
another thing is that the drugs, most of these our drugs is 3 to 5 days treatment. So after the 5th day, I was supposed to give some time to allow the animal, rest. So I told the owner that this animal is not going to die, that he should hold on. But before I could come back, he has already sold the sheep.
Oh. So that is one thing we encounter here too. So there's nothing you can do about it. It's his animal, and he has the leverage to do whatever he wants to do with his animal.
Yeah.
But when you have the pox, like sometimes it's itchy. The animals keep rubbing their body on rough surfaces like wall, like that. So apart from the antibiotics you give, you can also give antihistamines to the animal.
Okay.
To alleviate the nature of the disease. So just treat palliatively. There's nothing much you can do about it. And then you can give anti-inflammatory. Like these NSAIDs that I talked. You see the NSAIDs,
Yep.
they have maybe I should say triple advantage: anti-inflammatory effect, antipyretic effect, and analgesic
Fairly.
effect. These nodules are painful. So
Yes,
it
ma'am.
takes care of the pain, it takes care of the inflammation, and then even the accompanying fever. So we can give any of them to take care of these three things that will be disturbing the animal.
Okay, ma'am.
So any other question? Okay?
Mm.
I was thinking, well, you don't, well, it's like this thing, the lumpy skin disease. Sometimes even in this pox, the sheep and goat pox, sometimes these nodules rupture. Have you seen that before?
I did not witness one.
Especially the lumpy skin disease, it ruptures.
Yes, in lumpy skin
When it
disease, I saw one.
you need to do something about it. You need to dress that wound. If
Okay.
not, you need to dress that wound and maybe apply something that will repel flies. Because if you leave the wound untreated, there will be superimposition by bacteria and then it will complicate the issue. So you need to treat that wound, put something that if not, the flies can lay eggs, maggots, that will form maggots in
Yeah.
the wound. So you need to take care of the wound also. So any symptom you see, you treat accordingly.
Hmm.
Hmm?
Yes, ma'am.
Uh-huh. Any other thing?
No, ma'am.
It's already 3, 3 past 3. Are we taking 1 hour or 2 hours?
So, according to the information posted, the two courses have from 1 to 6, but I don't know how it was divided between the lecturers.
So I think like we are supposed to take 4 topics and we have had 2 now. If we can endure and take the other 2, I think we'll be done today.
No problem.
Uh-huh. So the next one is contagious eczema. That one you've seen it before too, isn't it?
Yes, ma'am.
Contagious
I,
eczema. So
I
these
think
are
it's actually one of the outbreak I'm having recently.
so it is also called contagious pustular dermatitis of scabby mouth or sore mouth. So you can call it any of these names, but the original name is contagious eczema. Then the etiology is the virus in the genus Parapox virus and the family Poxviridae. Well, it's primarily a disease of lambs and kids, that is young animals, because the older ones are more resistant to this disease. It's not as if they don't come down with the disease, just this. That's why I said primarily, but it can affect even older animals. So morbidity can be up to 100%, but mortality is usually mortality is low. That's case for case. You know the difference between mortality and case fatality. Case fatality is when you have sick animals. Number that die among those sick animals, that's case fatality rate. Then mortality is just the animals that die, not necessarily. There are some that the clinical signs are not very apparent. So that is just you see, it's not a very serious disease per se, because it's not a lot of them do not die. It's just a few animals that die of this disease. But because the morbidity is high, during the course of the disease, the animals they are sick, they don't feed, so it's usually something that raises concern, and it spreads fast in the herd actually. Next one, okay, rapid spread in the flock or herd by contact via inanimate objects such as feed troughs, air tag equipment, anything, any format can spread diseases. So even the clothing of the attendants can also spread the disease. This virus is a very hardy virus because if the scabs fall off, even in the dry scab, it has been reported to be able to survive for up to 12 years in a dry scab. So even if the animals get healed of the disease, you have to really take care of the environment so that in future other animals will not pick up the infection. Because it has even been reported in dogs that have eaten animals that have contaminated, maybe like animals that come in contact with maybe anything that causes the animal to die, because this animal is able to hang around in the environment. If animals had contact with this and died, so any dog that picks this that eats this, the dead animal can pick up this disease. So the economic importance is that it's not as if it's a disease that causes a high mortality rate, but it has economic because countries that are very particular about their livestock, they do not allow animals that come from countries that have off to come into their country, and they don't. That is, they're afraid of importation of animals that have this, so that they don't come and infect their own animals. So that is just important, and the economic importance. So restriction of trade is a very serious issue, especially for countries that maybe, let me say, depend on these animals for their income. And this disease has been reported to be zoonotic. So if you're handling an animal that has off, at least you should be able to take care of yourself, wear gloves, and afterwards you should wash your hands and disinfect. I think I have a picture of the lesions in humans. Well, the clinical signs, they have papules. I've told you what papules are. Papules, pustules, scabs covering the ulceration. Because after pustules develop, they will break. When they break, that is, they become ulcerated, and then after some time they are being covered by scabs. So this is how it progresses. So these scabs can fall off on their own naturally, but during your intervention also you can also pick up these scabs. Usually, one of the classical thing about contagious eczema is that it starts from the oral, the commissures of the mouth. You see it starting from the commissures of the mouth. So that's why, sometimes if you're not very experienced, you can confuse it with some diseases like, what is it called now? Mange. But this one typically starts from the commissures of the mouth and spreads to the other part of the mouth. So these lambs, the affected lambs, are not able to suckle. And for those that are able to suckle, that is how they transmit the infection to their dams. So I told you it's a disease primarily of young animals, but adults can contact, especially from lambs that are suckling, what is it called? From lambs that are suckling. So they're able to transmit because their teeth can cause a little injury on the teeth of the other. So because of that, they can have an establishment of the infection in the dam. So, but animals that have a serious oral lesions will not be able to suckle or graze. Then you have swelling of the lips. Well, when it becomes more serious, malignant form, it invades the alimentary tract, and then it can also go systemic and affect the coronates, ears, anus, and the vulva. So when it affects the coronates, of course, you should expect that the animal will be lame. You can see this is how it looks like. It starts from the commissures of the mouth, but sometimes you see these things very big. They become if you even lift up the lips, you see a very large granulomatous growth beneath the lips. So this is how the off looks like, and then it affects the hands. This is a human being, of course. It affects the hand and even the face of humans. So when there's an abrasion in the skin, anything that causes a breach in the skin, the organism can get. So from there, it moves through these stages: macule, papule, vesicle, pustule, granulation, scab formation, and then it resolves. I've told you it's a self-limiting disease. You know what a macule is? It's just a flat raised area on the skin. So it's a flat area that is just a little discolored on the then it forms papule, then forms vesicle. Then vesicles sometimes it gets superimposition by bacteria, and then it forms pustules, then later granulation. That is why you have those swellings and then later scab formation. These scabs can fall off and then there'll be a resolution of the condition. Diagnosis, usually clinical signs, and then by identification of virus by polymerase chain reaction. Like other viral diseases, there's no specific treatment. You just treat palliatively. So, well, even before now, I've told you some of the palliative treatments you use. Number one, you give antibiotics to guide against secondary bacterial superimposition. And then you can also, this was the one I told you, typically you can regress the lesions by use of astringents like alum. So you can use it to scarify the area, and then you see a dramatic change in the lesions. So treat with antibiotics, anything that can help in wound healing, you help the animal to recuperate fast, and also you should give soft feed to the animal so that it does not injure the mouth. I think that is that with the treatment. Then for prevention and control, since contact can bring about infection, so isolation of infected animals is very important. And then biosecurity, as in you should try not to transfer, maybe we should, it can also be transmitted by fomites. You should maintain strict biosecurity, disinfect, and try not to use the same equipment on different groups of animals. Then it can be vaccinated against, but I don't think, and I don't know about the availability of this vaccine in Nigeria. I've not come across it before. But a lot of things are, these elites that bring in animals from different parts of the world, they import different sorts of vaccines, but it is not being produced in Nigeria, as far as I know. I think that is that. If you have questions, please ask about contagious eczema. It's one of the diseases you like. You said diseases are self-limiting. So it's a self-limiting disease. But I think it should help the animal to recover faster.
Okay, I actually, I don't know what to say, but it's a good one. But what will you say is the coming to the differential diagnosis? Coming to the differential diagnosis, can you actually help us with the difference between this contagious eczema and is it blue tongue?
Blue tongue.
Yeah.
Blue tongue is not very similar to contagious eczema because in blue tongue you have cyanosis. Usually the oral area is usually cyanotic. So that is very distinct from this one. It doesn't even, it's not, this one has scabs. Blue tongue does not have scabs. That one you have cyanosis. In this one you don't have cyanosis. So I think what I think should confuse you with this disease is mange, because a lot of times you see mange presenting with something similar to this. So you can differentiate from how the lesion started, and then also this one you have scabs, but usually in mange the lesions are crusty. You know the difference between crusty and scabby?
Yes, ma'am.
When you say scabs, you can peel it off. When you peel it off, like what you have in dermatophillosis, when you peel off scabs, the underneath is going to be raw. What you see in mange, it's powdery. When you squeeze the lesion, you see it falling off. You understand?
Yes, ma'am.
So this one is crusty and this one is scabby for mange, and then this one. And then you see in mange, you see a lot of areas of alopecia because it's caused by mites. they burrow into the hair follicles. When they damage the hair follicle, the hair falls off. So because of that, you have areas of alopecia image, which is not what you see in this case. Any other thing? But sometimes you can
No.
even confuse it even with tumor, especially when you have the large granuloma in the mouth. You see the mouth being very big, and well, you see you can differentiate that because you see you can even ask for the most of the time the cancerous growth is usually it takes some time, and then the way it spreads. When you have a tumor, you see it's just one animal that is affected. But this one, especially if they are in contact animals, it spreads. All of them will have, almost all of them will have the infection. So there are some key points that you look at when you want to differentiate between these diseases.
Yes, ma'am.
Ask, please.
Maybe I'm having one confusion over one particular case I treated, which I snapped, and
Over.
a particular case I treated recently, which I was able to snap, and in that case, the lesions appear similar, just that what you did not mention is that I noticed some lesions on the tongue. I don't know if I can even share the picture here. I noticed some lesions on the tongue of the animal. So I don't know if that one is maybe off, that has been complicated with another disease. And then sometimes some of this disease comes with diarrhea, while some does not have diarrhea. So sometimes I just blame it on.
What was your diagnosis?
I was looking at off.
You are looking at off.
Yes.
Since I didn't see it, I will not be able to say yes or no. But you can see the clinical signs we have mentioned for off. You see, it's possible. You see, I told you that when you have a viremia, it spreads around the whole body. Most of the time, it doesn't spread actually, but there's a possibility that it spreads. So when it spreads and it affects the alimentary tract, there is a possibility that the animal will have diarrhea. You know, when there's something in the alimentary tract, the body will try to respond and we want to eliminate that thing. So because of that, it causes increase in GI motility. So it can result in diarrhea. Well, I can't really say because I didn't see the one you handled, but I think it could be a possibility. Was this scabs or crust that you saw?
It looks more like crust.
Crust.
I'm trying to see if I can share with you right away.
Mm-hmm. You are looking for a picture, right?
No, I've seen it. I'm just trying to share it with you.
Okay.
I just pushed one to your WhatsApp now.
Okay. Let me get my phone.
Let me see if I can.
The data has been off since the entering. Let me see. Okay. For this one, I can't see scab here. Was there a temperature?
Yes.
Was it high?
It was high. 41, 40, 40.
Huh?
41, 40, 40.5, 41 degree.
41. What I'm seeing on the skin, what does it look like? Are there lesions on the skin?
On the skin, there's no lesion on the skin. It's just on the
It's like I can see
nose that
some
you see.
bumps. This whitish lesion in the mouth, what is it?
They are like noodles.
Are you
They
sure they
will
are
rupture.
noodles?
Something
Because
like
this thing I'm
viscous.
looking at looks more of PPR to me. Was it only one animal that was affected?
Many, and it have this smell once you open the mouth.
Now it looks more of PPR. This is not contact. You can see the way the nose is. This is typical of PPR. Yeah.
But not all of them comes with diarrhea.
So you know they will be in different stages. They cannot all have diarrhea at the same time. These ones are
Okay.
incubating it. These ones are manifesting the signs, but this one does not look like off. Those dry things you are seeing there is just dried mucus. You see, when you have
Okay.
off, definitely you see it at the corners of the mouth. And then you see, when you have PPR, you see the tongue is looking whitish, isn't it?
Yes, ma'am.
So when you have PPR, it's like somebody that drank hot water, not warm water, and it burns the mouth. You see that there'll be like a pseudo membrane, there'll be like a membrane on it, isn't it?
Yes, ma'am.
So that is the erosion, because you can peel up that membrane. That looks like what I'm seeing in this picture.
And then this picture, the nose was completely blocked with, let's say, catarrh. Then I have to clean it up in order to snap the picture.
So this is more of PPR, please. It's not off.
Okay.
But maybe luckily for you, you used antibiotics, which can be applicable in both diseases.
Yes, ma'am. Yes, ma'am.
This is more of PPR. You can see the nose, you can see the mouth. Though the ocular lesion is not very evident, but at least I can see some things in the eyes.
Yes.
This is
Yes,
PPR.
ma'am. Let me give you this one. Maybe this picture will show you something I'm seeing. It's coming over.
Another one, let me see.
A minute.
Okay.
Yeah.
Doctor, this is PPR.
Okay.
This one is the topmost layer that is trying to slough off. That is what you are seeing there.
Oh.
It's PPR. This is even typical of PPR. It's PPR.
Wow.
It's PPR, definitely.
Okay, ma'am.
PPR.
The majority of them are responding, but the pregnant ones don't survive.
Yeah, it's PPR. You see, it's not very serious that will cause. You said pregnant ones don't survive, they die.
Yes.
You know, it has to do maybe with stress on their immune system. These ones, they affect immune system. Though some literature said no, but a lot of literature said it has an effect on the immune system. So when the immune system is compromised, and you see also the stress of pregnancy, so there's going to be a problem. But with these pictures you have shown me now, it's PPR, it's not off. You want to share another picture?
Okay, ma'am. No, this is off for.
Sorry?
Unless I share it. This is off for the off, unless it is the one for sheeppox.
No. Which? Okay, you have a picture for sheeppox.
Yes, ma'am. In a minute.
Ma'am, let's just continue. Once I get it out, I will
I'm just
notify.
trying to save your number.
Okay, I've seen it.
Okay, you seen it. I'm just trying
Yes,
to
let me
save it.
forward.
That's Are you sending it?
Yes, it's already there loading.
Okay, Fox.
In sheep.
Yes. Yes. So how did you handle it? Why is it only
That's the
the head
one.
you're snapping? Is it not on the body?
Ma?
Why did you snap only the head?
Sorry, it was also all over. I just want to show you the hair, but just as it is on this side, that's the way the whole entire body is
Yes,
rough
that's going
and
to be the whole of the body. So you just tell them the animal may recover, but the lesions will disappear gradually. It's not going to be dramatic. So that's what you should tell them.
and
But
there was this.
from the treatment, are they responding?
Yes, when I give treatment, it responds very well, but the lesions are not going
Okay.
now.
That's what I'm telling you. It doesn't regress fast. It will go, but it will take some time. But the ones that are very large can regress. They will reduce in size, but they will not disappear totally until after some time. So that is that.
Okay. Then I noticed that the purulent discharge that was coming from the eye,
Sorry?
the purulent
I didn't hear
discharge
the
that
last.
was coming from the eyes also
Uh,
stopped as treatment commenced.
so let's take the last topic. The last
Okay.
topic is heart water, which is also a very important disease. Heart water, cardiosis. Caudia ruminantum, Caudia ruminantum was the former name, but it is now called Ehrlichia ruminantum due to this molecular whatever. They tried to rename a lot of organisms in the Rickettsia family. So that's why they renamed this as Ehrlichia ruminantum. Sorry, I didn't italicize it. I was in a hurry. So it's a disease that is caused by vectors, mostly Amblyoma variegatum and Herbrium are incriminated. But here in our locality, mostly it's the Amblyoma variegatum that transmits this disease. Any stage of the tick can get infected and they can transmit this disease to a susceptible host. So it's an endemic disease of cattle, sheep, goats, wild ruminants in Africa and in the Caribbean. Once an animal is infected and it's not properly taken care of, you have a high mortality rate. Even in our local animals, but exotic animals are more affected because they don't even have any level of immunity against it, so it causes high mortality in exotic animals. But even local animals, if they are not attended to properly, they usually the high mortality is usually reported. So tick inoculation, as in tick will transmit the disease to the animal. After inoculation, we have it multiplies in the local lymph node, that is the lymph node around the area of inoculation. After multiplication, the lymph nodes rupture, and then these organisms, usually they are found, they invade the blood, endothelial lining of the blood vessels. So because of invasion of the endothelial lining, because that is the genesis of their pathology, because after invasion, they cause permeability of the um, blood vessels. These blood endothelial cells are supposed to maintain, they serve as a barrier between the blood vessels and the surrounding. They determine what comes in and what goes out. But when there's a damage, so there's increased impermeability and a lot of fluid are being lost into the surroundings. So can, it can lead to respiratory collapse, cardiovascular collapse, and then other signs that are being seen. Because when there's increased impermeability, fluid moves from the blood vessels to different organs, especially in the heart and the pericardium and the thoracic area. So because of that, when that happens, you see the manifestation of the clinical signs. But apart from even apart from the heart, even the brain and other parts, that is why you see the nervous manifestation. It also causes um, inflammation of the brain tissues. So in the clinical signs, you have an incubation period of 1 to 3 weeks after transmission. So depending on the immune status of the host and the virulence of the infecting organisms, that determines the duration. So you can see that 1 to 3 weeks is wide. So if the immunity of the animal is very high, it takes a long time. If the immunity is not high, once there's an inoculation, the clinical signs will manifest very soon. So there are different manifestations of this disease. We have the paracute cardiosis. The paracute sometimes go unnoticed. You just find the animal die. So usually before the cases are reported, the clients will just call, we found this animal sick 1 or 2 days ago, and then the animal then there's a prostration, and then the animal dies. So, the client might not be able to determine if the animal has a fever or not. But if the animal is brought to the clinic and they brought on time to the clinic, then you will see that the animal has a high fever, there's prostration, and then there could be a history of tick infestation in the heart. But this, what is it called now? The host, this thing vector, amblyoma is a tree host tick. So sometimes they'll tell you that there was no tick on the animal. This tick will feed and fall. So it can have 3 different hosts for it to complete its life cycle. So you don't really, sometimes you don't really have to see the tick on the host before you make a diagnosis, because sometimes you miss your diagnosis if you don't see the ticks. But some other times you see the ticks on the animal, you see the amblyoma on the animal. So, and then with the manifestation of the clinical signs, the presence of the amblyoma, you'll be able to say, yes, this animal is suffering from cardiosis. So what I'm just trying to say is that you should not rule out cardiosis when you are seeing signs, because you are not seeing ticks on the animal. The ticks can feed and drop. So for the paracutes, I told you that it's just something that happens in 1 or 2 days, and then the animal dies if 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 not attended to. Then apart the next one is the acute form of the disease. Also, you have sudden febrile reaction. Then the animal, these other signs are not specific: inappetence, listlessness. Then rapid breathing, because a lot of fluid have been withdrawn from the circulatory system, and the animal has to compensate. So because of that, you have rapid breathing. So, and then the classical nervous signs. This acute form of disease is the most reported one, because you have padding movement. Well, some clinicians, if they don't see the padding, they say, no, it's not cardiosis. It doesn't necessarily have to happen. But most of the time, you see, the animal will be on lateral recumbency, and then it's as if it's riding a bicycle. So you see the animal paddling. Then you have ataxia, when the paddling stops and the animal moves, you see the animal, the gait of the animal is the ataxic. So also coordination. Then you have twitching of the eyelids, cycling, aggression, apparent blindness, recumbency, convulsion, and death. So it follows this chronology sometimes, and sometimes, not always, you can have a profuse fetid diarrhea. Then the subacute form of the disease, it will show similar clinical signs as the acute ones, less severe. And then it's less severe, the animal can come out of it. Then the mild form, well, it can even go on. Then for the diagnosis, most of the time we make our diagnosis here based on clinical signs, which especially the nervous signs and the rest of, and nervous signs associated with temperature, and then also auscultation. Auscultation is very important when you do an auscultation, because the fluid, hydropericardium, hydrothorax, and this fluid is able to transmit the sound all over. So usually when you are doing an auscultation, when you auscultate the left part of the lungs, that's where you hear, especially around the elbow, that's where you hear the heart sound. But when there's scoliosis, you can hear the heart sound everywhere, even on the right side. So anywhere you put your stethoscope, sometimes even in the abdominal area, you hear the heart sound. So if you hear that, that is almost, let me say, you're almost 100% sure you're dealing with cardiosis, because this sound are being transmitted in this fluid medium all over the body of the animal. So you'll be able to pick heart sound anywhere in the body of the animal. But unfortunately, well, the fluorescent antibody technique is being used for diagnosis, and the ELISA. These tests are not very common here in our locality. So most of the time we base our diagnosis on clinical signs, and then if you want to do a confirmatory diagnosis, it's usually after the animal dies, which is postmortem. That is the demonstration of the ehrlichia in the brain squash, using a brain squash smear. So that is what is done. Then this, apart from the fluorescent antibody technique and the ELISA being maybe, let me say, expensive, they are not readily available here. So even where they are available, they are not specific. So that is why they are not very common tests used for diagnosis of ehrlichia. They are not very specific. There are some other things that can react and show similar results as in ehrlichia. So for the treatment, so if you're able to diagnose the disease early, usually tetracycline is your best bet, especially the short acting. Where the short acting is not available, we use long acting. Well, it is not recommended, but it is used in the field. Even the long acting, people give it intravenously. But usually the conventional treatment is you use your tetracycline, short acting tetracycline intravenously. Then maybe subsequent ones, you know the short acting you're supposed to give every day. So if you give for the first 3 days, you see that the animal is improving, then afterwards you can give the long acting, then so that it will cover for, you extend the period of treatment. Or you can give in divided dose. You can give half of the dose intravenously and the rest of it intramuscularly. So for prevention, usually vaccination, which we don't do here, but it is done in some other parts of the world. The vaccination can be done, and then also tick control is very important, since it's the way the ticks are the ones that usually transmit this disease. So if you control the ticks, at least you'll be sure that this the ticks are not there to transmit the disease. So also chemoprophylaxis can also be used, usually where maybe after you suspect that something, maybe tick infestation or things like that, oxytetracycline can be given long-acting to the animal, at least if there's something there, it is taken. So chemical prophylaxis can be oxytetracycline, it control. That is the last slide. So ask your questions. Let me get my paper because maybe you have plenty of questions.
No, no.
But I hope I was not just making noise, we are understanding.
Yes, I was understanding. I was
Oh,
understanding.
I hope I was fast.
No, you were not that fast.
Because I just wanted us, at least I want you to understand, but at the same time I want to, because this is our last official time.
Yes.
Oh, but if you need something or you want us to do something, you can do it unofficially. So after today, I'll call Professor Talabi from Ibadan. He'll be the one that will take you, I think, from African horse sickness down to African swine fever.
Okay, ma'am.
It was just, I think, yesterday or the day before that I was able to speak with him. All this while I was not getting through to him.
Wow.
Oh, he's a professor. Even if he doesn't prepare anything, he can give you a lecture.
Okay, ma'am.
And now he doesn't have to. Doesn't need to.
Okay.
So ask him a question, all of them, but especially hot water. So you see that I got his name from hot water.
Yes.
Have you treated one before?
No, ma'am.
Not treated one. So this is how you, if you intervene very fast, at least it's when once this thing starts, give 5% oxytetracycline IV. Even if you cannot repeat it the next day, and even if you cannot continue, just at least that first shot should be short acting. You see that God willing, the animal will improve. So in case you come across it, because it's an endemic disease.
I don't know if we will have time. I would have said let's maybe look at the clinical science once more because you were a bit fast there. But if there's no time, I can just go back and review the video on my own.
Where is the clinic? This one?
Yes,
What type
starting
of-
yes, starting from the acute one.
That is where you see all the clinical signs. So you see, I told you when this thing becomes systemic, it goes to different organs. So it affects the brain.
Mm.
You understand? So
Yes,
that's
sir.
why you have ataxia, paddling movement, twitching of the all these ones are nervous signs that you
Nervous
see.
sign.
Signs that you're seeing are nervous signs. And then you see congestion of the mucous membrane. You see, when you see congestion, it means congestion of the mucous membrane, like I told you in, was it in PPR? When you have a lot of fluid, water moving out of the blood vessel, so
Yes, ma'am.
there's going to be hemoconcentration. So that because, well, I don't think it's here, but you also have congested mucous membrane in this disease. So when because the water has moved, fluid has moved out of the blood vessel, you have it has an effect on the endothelial lining of the blood vessels. So it allows water to move out of the blood vessels. So because of that, you have congestion. And you can also see what will even complicate it further is the diarrhea. Apart from the animal is losing water through diarrhea, it's also losing water from the compromise of the blood vessel. So because of that, you have congested mucous membrane. You have a temperature because of the activity of the organism in the system. And then this nervous signs that you are seeing is because it affects the brain.
Mm.
I don't know what question do you have particularly on the clinical signs.
This protrude
profuse fetid diarrhea is can you please explain it a bit?
Profuse, something that is plenty.
Fetid.
Isn't it? Plenty is much.
Okay.
Are you hearing
Okay.
me?
Yes,
So
ma'am.
that is profuse. When you say something is profuse, it's plenty, it's much. Then fetid, it's smelly, it's not smelling nice, it's smelling, it's offensive.
Okay.
So that is what I mean. Profuse, it is profuse and it is fetid.
Okay, ma'am.
So in most cases of caudosis, you have this. It may not be in all, like our teachers tell us that disease don't read books. You may not see all the signs in one animal. It can even be just one sign you are seeing. You can see if you don't see the what is it called now? The nervous signs, you may not be able to diagnose this disease because you get confused. Because if you just see an animal that has profuse fetid diarrhea, you can confuse it with PPR, isn't it?
Yes, ma'am.
In cautrosis, you will see these nervous signs, but all of them may not present in the same animal. You can have 1, 2, or 3 of them presenting.
The nervous sign.
Pattern movement is typical.
Okay, that's what I want to ask.
So you just see the animal will be on lateral recumbence. It will be paddling, it will be moving the legs as if it's riding a bicycle. You know paddling now, isn't it?
Yes, ma'am.
When you paddle, it will be as if the animal is riding a bicycle. So that is how it looks like.
Okay, ma'am.
Other question or question?
No, for now, no.
I said for now. Later, maybe it will come up later, isn't it?
Yes, ma'am. When we encounter the case in the field, when you encounter the case wrong in the field, then you will know that there are questions you should have asked that you did not ask.
Well, sometimes, after everything, you can still ask questions after you have finished. Anytime you encounter a case, if you can assist, you can contact, and then we'll try and see how we can assist.
Okay, ma'am.
Like what sometimes it's when you get to the field that you see that, okay, I should have asked something that I didn't ask.
Yes, ma'am. And here I am. There is nobody coaching me per se. It's from afar, you understand? So I will really ask you a lot of questions. I hope you accommodate all the disturbance.
But when they pay you now, we'll share the money. Pay for consultation.
No problem.
No problem. By God's grace, I hope I'll be able to assist.
Amen.
So, welcome at any time.
No problem.
If you don't have questions to ask, I think we have come to the end of our presentation. I will notify Professor Tomori and Professor Talabi
Okay.
that we are done. So, absence of questions, I think maybe we'll call it a day. Hope you are okay. Is Prof
Yes, ma'am.
there? Okay, Prof is not around today.
Yes, he's not around.
But are you the only one in this specialty?
I was told that I am not the only one and that they will soon give me the contact of the second person, but I have not received any contacts yet.
Oh. So it's okay. And thanks for technology. You didn't have to come down, only you be in class. So you were the only one. Eventually we'll have to come for the practicals. In the absence of anything, let's call it a day. Have a nice day.
Thank you, ma.
Bye.
Mm. I want to see if I can contact him. Okay, man. So once I'm not, no, I just let me contact him, but I checked online and I saw two of you reported one case, one interesting case in staff. Can you hear me, ma? Hello, ma. Can you hear me, ma? Hello. hear it.